So we have few minutes for discussion, and of course we are going to engage the panel. I do see many esteemed colleagues in the audience, and I would love if you make use of the microphones in the hall and share some experiences you've had with any of these techniques. Great cases are done in every cath lab, and everything gets archived in our Accelera. So this is a forum where we want to bring out those experiences, share it with us, and every day there are new things being done. So please feel free to share this, and anytime you have a point to make, please step out to the microphone. Let me take it to my colleagues here and ask them that, the whole idea that has been promoted in our field, if you have heard it, is a quick transition from one approach to another. Now, I'm not talking about those who do it every day and they are highly skilled approach experts. I always like to focus on those who are about to start this program and take it on. Now, where and how do you prepare yourself? Like, for example, you are doing a long SFA occlusion with a small nub which extends into the P2, P3 segment of the popliteal artery. Now, in that case, will you prep for a AT approach? How will you prep it? Do you also prep for a pedal approach or anterior posterior tibial approach? This can be pretty cumbersome for a cath lab. So, starting from the extreme left, if you can tell us that how do you do this? Are these cases planned in advance? And how do you let your lab be prepared for this kind of approach, including using the ultrasound tech, which is not always available?
Yeah, in our approach, when I first went to Brown, we didn't have a dedicated ultrasound, and that was really, in my mind, one of the first priorities. And although we have wonderful ultrasound techs, they're really busy down the hall in a non-invasive lab. So we took it upon ourselves to become facile and be able to run the machine, and we had our ultrasound techs come over and train our cath lab techs and our nurses to be able to do all the basic functions in terms of the ultrasound machine. So we get ultrasound access on 100% of our cases, ultrasound guided access, and when we prep the patients, we basically prep them from their hip to their toes. And so that way, if we are unsuccessful in getting antegrade, we've already got the foot prepped and draped and ready to go. Obviously, you need to have a hockey stick probe for the pedal access and a regular probe for the femoral and popliteal access. And so, one thing that we didn't really talk about during this session with these long occlusions, I mean, we really focus on sort of access, but there are certain adjunctive tools that you can use to make the crossing go more quickly. So we didn't really talk about dedicated CTO devices like Crosser or Frontrunner, but these are all tools that we have in our lab. Most of the time, of course, you can usually get through just with a good old-fashioned glide wire and a 035 quick cross. But in certain cases, especially if it's at a premium where you want to be intraluminal, sometimes it may be worthwhile to invest the extra time and money in a dedicated CTO device, particularly if you're considering doing atherectomy where you really want to try to stay in the true lumen. But we give it maybe more than 10. Mehdi in his paper gave it 10 minutes. I think we probably give it maybe about 15 or 20 minutes. So if we're not making any headway antegrade, we have a very low threshold to just, again, because the ultrasound is there and everything's prepped and draped, to just go ahead and access with ultrasound guidance down at the foot.
Arthur, the same question to you. Do you do it each time, or there are occasions that you do and some occasions you don't do?
Do what?
The prepare for a retrograde access.
Especially if there's CLI patients, we prep the whole leg just like you guys do. Surgical prep, the whole leg is exposed. Claudicants, we do it a lot. In that case, probably up and over, just to have the advantage if I am retrograde, sort of I'm all on the same side of the table and not working both ends. I think it's important to, even for beginner operators to sort of, not do the same thing over and over and exhaust themselves. Because when you have, especially a CLI patient where there's multi-level occlusions, there's, plan A, there's plan B, but there's also like plan M and O. So if you spend all your energy on plan A and B, you don't give the patient the benefit of all those other things. So you really have to, sort of allot the time, ration your energy so that you can do A, B, C, D, at least give them the benefit of trying all these things. And at the end of the day, if you fail after you've gotten to plan G, I think you've done your best. And there's no harm in stopping and bringing them back again or referring them to a more experienced operator is the bottom line.
Mazin?
Yes, thank you very much for the very instructive course you had here. All your rendezvous approaches really reach the rendezvous level. In other words, I come across sometimes the superior portion of the popliteal artery is closed. The tibio-peroneal trunk is closed. Coming the pedal axis and coming from the antegrade, you can't advance to the antegrade approach. You can still advance to the pedal approach. So that segment, let's say, which is 6-7 centimeters, what do you do to make that rendezvous happen?
Well, that's a great question, and I'm going to throw it open. I think Arthur showed some strategies where he was able to dissect and then use a balloon to re-enter. I think those are some of the advanced strategies that can be used in those situations. And those, I'm sure Arthur can confirm or deny that he probably uses them in those situations where there is a hard distal cap to cross.
Yeah.
Take it away.
I mean, I think access is one thing, but crossing is, why I say access is key, crossing is keyer. So, you have to be comfortable with all these different accesses, but at the end of the day, a lot of times you're subintimal both ways. And most commonly, the most difficult place I find is in the popliteal artery, because you can be really far off in the popliteal artery. If you're fairly close, you always check it in two angles, make sure the wires are as close as you think they are, because, you turn all of a sudden they're like this. If you're close enough, I like to do two balloons, parallel balloon technique, double balloon fenestration, because I think that works a high percentage of the time. In some cases where that's failed, or I really want, where it might be a little further, then I'll bring the outback in from above and puncture the balloon, and that usually gives you a sure fire. Now, if the wires are really far apart, what I would do is work on both ends to try to get the wires to take a different path. Okay, so I'll bring an angled catheter from both directions. I'll advance the catheter without the wire to try to dig into a different tissue plane. I'll take a non-hydrophilic, like a CTO wire, that will basically grab the tissue slightly differently and just get closer in both, in both directions, so that in the popliteal artery, instead of 5 millimeters, you're, 2 millimeters away from each other. The other thing, if you do the double balloon technique, is I always recommend using the right size balloon. So in the popliteal, I'll use 5 millimeters from both sides. I don't overlap much at all. I put the distal markers right up to each other. I use 5 millimeters. Tibial, I'll use 3 millimeters to do the ripping. SFA, 5-6 millimeters. And I find that gives you the best success. So you got to be comfortable with the card, reverse card, and all those other things that we showed.
There is a technique described in coronary, which I think a modification of which Dr. Schmidt showed this morning, which is called the open sesame technique. That whenever you have a cap that you cannot cross very easily and the wire deflects, you can take a balloon and wedge it into the proximal or distal cap, depending upon the size and the support wire, and inflate the balloon. And that cracks and shifts the plaque in a direction that gives you some track to either most likely go subintimally across, and then Arthur's technique of facilitated re-entry comes into play. So some strategies, but great question. Please introduce yourself and your question or your comment.
Charles Duncan, I'm from Scripps Clinic in San Diego. Thank you very much for the excellent talks. Can you speak to the use of embolic protection devices, filters, as well as intra-arterial thrombolysis in the management of CLI?
Intra-arterial thrombolysis and distal filter protection. So Munier and Kevin?
So really, when I do atherectomy, I do protection devices. Especially that we had a lot of disasters that you open the vessel proximally, you end up occluding distally, spending 2 more hours to clean that artery. But if I'm going distally, I don't, because you are protecting it by your sheath already. It's not going to flow to you. You'll suction it, and that will take care of it. This about thrombolysis, if the patient comes with acute on chronic ischemia, then you can use, even if you cannot cross the lesion, you can just put your catheter proximally, bring him 6-7 hours later, lyse it. You'll be astonished how much you can pass those. You can see lumen sometimes, or a small channel. It is more in the venous side than the arterial side, but it should be acute on chronic to work well, really, not like the venous. Venous works better.
Kevin, any comments, please?
So my algorithm is pretty simple. Every time I use atherectomy, I use a filter if I have room. Anytime I think the lesion is thrombus, I use a filter if I have room. I think we can get faked out sometimes. I think patients may have maybe thrombosed their SFA. They present in a time frame that seems like CLI, and then we need to recognize that, so we treat their lesion as old thrombus and not as calcium, for example. So I think it's important to try to distinguish late presenting ALI from CLI so we deliver the right therapy.
I want to cite a very important paper. We from Dr. Nicola Shamas, and before that, a comment is that we in 2015 we looked at predictors of embolization. We were surprised that CTO came up as one. Unlike coronary CTOs, peripheral artery CTOs are segments of occluded segments interspersed by areas of debris and fibrocalcific and even thrombotic plaques. So you could have that. So what Dr. Shamas and his colleagues showed with the use of jet stream, a very unique strategy, that they came very close to the distal cap, but they did not cross it. And they used jet stream to actually atherectomize and aspirate the content before crossing the distal cap. That way they minimize the risk of distal embolization. I can't endorse this because I have never done it, but I have seen this published and reported. But I think your concerns are correct, and the points that Munier and Kevin make around ALI, I think probably are very, very appropriate. I hope you got an answer to your question. Please, Munier, please.
So really for beginners, when I started, I depended on the company reps because first of all, to accommodate what are the catheters, what are the wires. Being a surgeon, I resisted for a long time to do it. I got trained in it, but then I started working, and then after I knew the techniques, I went for a 3-4 days course, extensive course really, day and night, seeing those cases. You'll come back with more confidence. Don't shy to call the company rep to sit with you because he is seeing everybody, how is he doing. They know all the techniques. Believe it or not, better than me, better than anybody else. Because this doctor tried this doctor tried this, and do what they tell you. Usually it works.
Peter and Arthur, any strategies and tips in terms of, do you guys do live cases and training sessions in your lab? I know you guys do a lot of retrograde.
I do training courses, that basically specialize in below knee access, alternative access. Potentially, sometimes below ankle if it's really advanced, but I don't do any live cases, which I'm kind of happy for. But I do training courses.
Peter, do you do training courses in your site?
Yes, we do training courses with the focus typically based on whichever company is sort of sponsoring that particular training course. We have done live cases. Most recently, we did cases for the C3 conference. And then we also have done transmission cases overseas as well.
I actually did not mean transmission, I meant live courses on site, because I think the comments made here by our colleagues is that we need to get more people involved in getting to do this, and I see therefore CVI as a forum is encouraging folks to open up their labs and endorse more cases and courses so that people can come and watch you. Because most of us, if we put our minds to something, we are going to get it done. And starting off on the right side and seeing the right techniques being exposed to them early on probably cements those and reinforces those techniques. So Munier, do you have final comments?
So we have actually the largest or second largest simulation lab in the country now. And we are doing it with companies on cadavers, believe it or not. It's much better to do on cadavers because you can make mistakes, you can do anything you want, you see things by ultrasound, and especially for accesses, how to advance the wire. It's very easily done. Then sometimes we do some cases live, but they cannot go to the lab. It depends on the hospital.
On the first floor, there is a pedal access workshop going on. Arthur was there sharing his extreme techniques and strategies. So I encourage you to make use of it. Are there any comments? Shoaib, you had a comment?
Yeah. So I don't know. And I don't know, I have tried one technique which I don't know, how accurate it is. But 3 times it has worked. What I've done is 035Y balloon. I took it into the CTO. And obviously once you are going with the 014 system and now you can't progress any further, so what I do is I take the 014 balloon or the support catheter out and put the 035 balloon, jam it into the CTO, take the wire out, and then I inject a little bit of saline. As I'm injecting, I'm also advancing my 014 hydrophilic wire. And it has worked.
Well, in coronary, it is called the Carlino technique, which is called hydraulic dissection. You can patent it, Shoaib, and you can be actually very rich. So if there are no other comments, I think we're going to close the session here. I encourage you to ask questions of our panel, and of course want to thank you all for making this meeting worthwhile for you and, of course, for us. Thank you very, very much.